There's an interesting study. I don't know if you saw the same one. I don't know if it was the one in your webinar where it was knee replacements, and they did a placebo sham study.
Yeah,
And with cupping, it's kind of like it's not massage, but it's similar in that it's a superficial thing, right?
right.
And with not that there's not a physical change, but it's something that's very superficial, not huge, and like not a significant change. And so with the placebo effect, I think people always think of like, well, nothing really, like the sugar pill idea, right? But
Right.
for instance, this knee replacement study was that they had two groups, and maybe you can speak to it better than I can, and one got the knee replacement and one didn't. And was it after 12
Yeah.
weeks they had similar outcomes and pain level?
Yeah.
Was that it?
Yeah. I think it was a meniscectomy. I don't think it was a full knee replacement.
Oh, okay.
But basically these doctors just cut open the knee, did nothing inside in the sham group, and they did just as well as the surgery group. And
Mhm.
some people still felt better, even though they just cut their knees open with a knife. So if I told you I'm going to take this scalpel and cut your knee open, and you'll feel better, you'd say that's nuts. But if a doctor's wearing, the white coat and they put you under and they do the same thing, all of a sudden you feel better. So it's the placebo effect. There is always that element that if you think you're getting better, if you think the doctor is competent, if you think your physical therapist is competent and you trust them, then you actually will improve your outcomes.
Which is interesting because it's like, should we focus on improving our treatment style, or should we focus on becoming a better communicator, right? Because if the placebo effect is something that's very important and obviously won't work for everybody, but if these, how do we prove that the treatment is actually working versus the patient just likes you?
Right. That's a great question. I mean, well, just to speak to that, in terms of that, what you just mentioned, I find with my colleagues that there is a bias in terms of like bedside manner. A lot of people think that it's just innate and they feel like their clinical skills are way more important than their bedside manner skills.
Mm.
So, one of my goals in teaching my webinars is to demonstrate from my own experience. It's very hard for me to prove it. I just know from my own experience that bedside manner is equally as important as clinical skills, and B, everybody can improve. Because I usually ask the audience, do you think you can improve on your clinical skills? And everyone pretty much says, of course. But then when you ask people, do you think you can improve on your bedside manner skills? Very few people say, of course, because they take it as like an innate criticism. If you're not good at bedside manner, then you must not be a good person, or you're not a personable person. Nobody wants to feel that way. So my goal is to try to show that it's a skill set. It's just like clinical skills. It's very difficult to prove, though, that whether it's the clinical or the actual bedside manner aspect. And I think it's a combination of the two. So it's not really the question of how much importance you place on one or the other is, I think, subjective somewhat. But in my experience, it's more 50-50 than it is, 80% clinical. So that's what I've experienced.
Yeah, and one thing that I found interesting, I think there's a word that a lot of institutions probably use, and I learned in PT school, was like biopsychosocial model, and making sure you're
Yeah.
using multiple areas to treat the patient. And so I think that is important. However, I think I'm seeing a couple people treat in a way like, oh, this is a biopsychosocial patient, or this is just like a need, like this is somebody who needs like extra attention, and like this person's just a meniscectomy, or like it's almost like labeling an individual based off of their issue. And I guess how do you stay objective in saying like, I'm going to be biopsychosocial with everybody? Like, some people are going to need talking to, some people really just need exercising to get back to where they were. And how do we avoid this like labeling that I keep seeing, where you're like, oh, this person's like got chronic pain for the past 9 years, and they're over objectifying their pain? How do you kind of
I
stay?
mean, I think the best way to do that is to use like a screening tool of sorts. I do in one of the webinars I give on home exercise programs. I saw an article where they used a screening tool to figure out which patients required more motivation, persuasion. It was based on self-efficacy, whether a person has high self-efficacy or low. So they would give out a screening tool in order to determine that. I don't remember the name of the screening tool, but I think at some point PTs should use kind of a screening tool to determine what the personality type of the patient is, how much belief do they have in themselves in terms of achieving their goals. It doesn't have to be sophisticated. It doesn't have to be like a 30-minute test. It could just be a quick, 2-minute, 3-minute questionnaire where you can develop an idea, a more objective idea about the person's issues and whether or not they're more physical in nature or they're more psychological in nature.